to today's Power Hour. I'm Audrey Vernick. I'm the Director of Patient and Family Advocacy for the Pediatric Epilepsy Surgery Alliance. We are the only nonprofit solely dedicated to supporting families through every stage of the epilepsy surgery journey, from drug resistance to surgery through recovery, school reintegration, and the transition to adulthood. We empower families with research-based support services and impactful programs before, during, and after surgery. Today's session is presented by the Pediatric Epilepsy Surgery Alliance in collaboration with the TSC Alliance, the LGS Foundation, and CHAD's National Resource Center on ADHD. We're so grateful to partner with these incredible organizations to bring this conversation to our communities. Today, we're honored to welcome Dr. Shafali Jeste to discuss understanding neurodevelopmental disorders after epilepsy surgery. Dr. Jeste is the Chief of Neurology at Children's Hospital Los Angeles and Professor of Pediatrics and Neurology at the UCSC Keck School of Medicine. She's a nationally recognized behavioral child neurologist whose work focuses on autism, ADHD, and developmental delays in children with epilepsy and genetic conditions like tuberous sclerosis complex. Her research has shaped how we diagnose and support children with complex needs, and she's built several family-centered clinical programs that provide specialized care for kids with neurodevelopmental disorders. While Dr. Jeste is not an epilepsy surgery expert per se, I first heard her speak at the Epilepsy Awareness Day at Disneyland a few years ago, and I immediately knew her insights would bring tremendous value to our community. My son had a hemispherectomy at age 2 after more than 2 years of relentless seizures, but it wasn't until he was nearly 10 years old that I began to understand what neurodevelopmental disorders meant for him and for our family, and I'm still learning how to say the word. That's why today's conversation is so important. Epilepsy is not just about seizures. The conditions that lead to surgery, like genetic syndromes, brain malformations, or early brain injuries, often come with lifelong developmental challenges. As parents and caregivers, understanding how epilepsy intersects with behavior, learning, and development can help us better support and advocate for our children. Dr. Jeste is here today to help us do just that. So Dr. Jeste, thank you so much for being here. We're honored to learn from you today, and you can go ahead and share your slides and get started.
Well, thank you so much, Audrey, for inviting me and for all of you for taking time to be here to listen. Yeah, please put questions in the chat. And Audrey, if there's anything that seems really pressing that requires an interruption, I'm happy to get interrupted during the talk. So hold on, let me share. Okay, so as was mentioned, I am let's see, why is this looking small? Hold on. I had this all nailed down before. Hang on, presenter.
That always happens.
I know. Okay, one slide. Are we good? You see one slide? Okay, great. So I'm a child neurologist. I specialize in neurodevelopmental disorders. We're going to talk about what those are, but that's autism, developmental delay, ADHD, diagnoses like that affect development and behavior. But I'm a neurologist, so I take care of a lot of kids with epilepsy. And as was mentioned by Audrey, there's a big intersection between epilepsy and developmental and behavioral challenges that our kids and adults face. And I actually always say that all of child neurology is neurodevelopmental, because any child with any condition that affects the brain, it affects behavior and development also. And so I think it's really important for everyone to kind of be somewhat well-versed on these diagnoses. My goal for all of you, since you're caregivers, is to give you some basic information about neurodevelopmental disorders. I am going to present some data like that just from papers that have been published, so you're kind of up on some of the literature, but I'm really going to focus on diagnosis and treatment, because I think that knowledge is what really fuels advocacy. And for you to advocate for the needs of your children and your loved ones, having some information in your back pocket can be really helpful. So this may be a review for some of you. For some of you, it might be brand new. I'll try to kind of give the range. And this gave me an opportunity to do a little bit of a lit search into what we know about development and behavior in the context of treatment for epilepsy and epilepsy surgery. So I have a little bit about that in the end. So these are my let's see, hold on to find my little, okay, there we go. These are my disclosures. Nothing really relevant to what I'm going to talk about today, except for the fact that I'm going to show you a little bit about one syndrome called DUP15Q, and that some of that work was related to work we were doing with Roche. So what we're going to do is talk quickly about what we know about the association between epilepsy and neurodevelopmental disorders. We're going to talk about diagnosis and treatment. That's really the meat of this, because that's where kind of the knowledge base comes in. And then we'll talk a little bit about considerations for clinical care in the setting of epilepsy and epilepsy treatment. And then we'll open it up for questions. Okay, so just to get us all on the same page to start, what is a neurodevelopmental disorder? So this diagnostic category is actually based on a chapter in the DSM, the Diagnostic Statistics Manual, which is basically a big book of behavioral and cognitive diagnoses that we make as neurologists, as psychiatrists, as developmental behavioral pediatricians. In the NDD section is global developmental delay, intellectual disability, autism, ADHD, and social communication disorder. And when we talk more deeply about diagnosis in the next section, we're going to focus on these three, because these are the three that actually we are diagnosing kind of most often. I know there's probably a lot of questions about ADHD that I'm happy to answer, but I'm going to focus on these three. So the key points with all these neurodevelopmental disorders is they're conditions that affect development at some point, right? So they have to actually have signs that occur early in development. They may not be picked up early, but when we look back at individuals who are diagnosed with things like autism or even ADHD or intellectual disability, there are signs that occur earlier on. So these are conditions that affect development. There's a lot of overlap between diagnoses. So never let someone tell you that if you have one diagnosis, you can't have the other. So they can go hand in hand. Also important, they're diagnoses based on behaviors. They're not based on a blood test or an MRI or an EEG or anything else that we can collect as a biomarker. It's based on behavior, which, as you can imagine, leads to a little bit of messiness, as we're going to talk about, because different providers, different examiners might have a different view, a different lens on a child. And so you might get variability in diagnoses, which is why having people who really know how to evaluate kids, especially those with complex issues like epilepsy, is really important when these diagnoses are being made. And again, a lot of variability. Like that's kind of our buzzword in our field, is like heterogeneity or variability, because you've met one child with autism or intellectual disability, you've met one child. It doesn't really translate necessarily to what another child might look like. Okay, so first talking about that overlap between NDDs and epilepsy, and actually I, with a few others, have written quite a bit about this over the years, but let's start with like neurodevelopmental disorders in epilepsy, meaning what do we know about these diagnoses in individuals who have a primary epilepsy diagnosis? It's pretty high, as I said. So the studies show that the rates of autism in epilepsy range from 5 to all the way up to 37%. There was a study that actually did a widespread developmental screening in an epilepsy clinic and found that actually almost 3/4 of kids screened positive for some kind of delay in their development. And a large proportion also screened positive for autism symptoms. So again, really high rate of neurodevelopmental issues in individuals with epilepsy. Not everyone, but certainly in a substantial number, which is why we have to take it seriously. And I will say that what I find clinically a lot is that sometimes when we're so focused on the epilepsy early on, which we need to be because that can be life-threatening, we sometimes forget as providers about the developmental diagnoses. Like we focus so much on the seizures and treating that we don't actually pay attention to the developmental needs of the child. And I always argue with my colleagues that we should be doing both at the same time. One should not preclude the other. And interestingly, also, I will say there's no gold standard recommendation, like for us as clinicians, in screening for developmental issues in epilepsy clinics, which is why there's like a big range in the kind of numbers we're seeing. But we know there's a need to be doing that kind of screening. Okay, so what about epilepsy in neurodevelopmental disorders? So now we're looking at like this concept of you have patients who have an autism diagnosis or intellectual disability. What percentage of those individuals have epilepsy? And it turns out, not surprisingly, again, we find a big overlap. So in the autism literature, it turns out that based on the studies, you can have up to 60% of patients in a study have with autism actually also have seizures. And it turns out in kids who primarily have autism, meaning they're diagnosed with autism first, the rate of epilepsy kind of goes up with age. So it's not that like they're at risk early on, and then if they don't have seizures by a certain age, they're not going to have seizures. So in my patients with autism that I see in clinic, I'm actually always taking the possibility of seizures pretty seriously. And if there are any spells that they're having or any events that are concerning, I'm going to work them up with an EEG and take it seriously. Just again, importantly for you guys to know, again, you're, I know, mostly caregivers of children with epilepsy, but for those of us clinicians who are taking care of kids with autism and the question of seizures comes up, it can sometimes be hard to tell if something's a seizure or not. And, you know, I think this actually applies to kids with primarily with epilepsy too. You know, you might have certain spells that are clearly seizures, and then there's new spells that arise, and you're like, are these seizures or are these behaviors that relate directly to the autism, like not responding to name, having some repetitive movements, right? That could be more behavioral, it could be epilepsy, and it's really hard. So what I always tell parents is if your child has new spells and you're not sure what they are, take a video, which I know you guys have probably all done quite a bit already with in settings in the past, but I always say take a video, show it to your provider, and we always try to capture them with EEG. That's the best way to determine if something's truly a seizure or not. And I'm gonna actually skip this next slide because I want to get to the, oops, it's being slow. Okay. So the question always comes up, and this is really important. We think about the overlap between epilepsy and autism. Like, why? Why is there so much? And I say autism, I'm going to say autism a lot because a lot of the kind of studies are on autism, but really think more broadly as neurodevelopmental. This applies to intellectual disability and some of these other diagnoses that we'll get into. But why is there such a big overlap between the two? And it turns out, like I'll say most things in medicine nowadays, the answer is in genetics. And so and we've learned about the genetics of both epilepsy and autism because of the fact that we're getting genetic testing a lot more than we ever used to. It turns out that if there's a child with a primary neurodevelopmental disorder, autism, intellectual disability, global delay, genetic testing is warranted. It's actually routine. It's recommended as the one medical test that any child with one of those diagnoses should get. Now, I'm sure many of you have had genetic testing, some of you may have not, and I'm sure there's a lot of variability in what kind of testing is done. And unfortunately, that's partly due to the fact that insurance coverage varies a lot, right? I mean, we would love to recommend whole genome sequencing and getting all the detailed genetic testing on everyone, but that's often not affordable and not covered by insurance. So the recommendations for actual genetic testing in a child with a neurodevelopmental disorder varies a bit based on our different professional societies. We actually wrote a review that kind of describes the different recommendations, but most places now around the country are getting a microarray, which you might have heard of, which is a test that looks for whether there's a big chunk of your chromosome that's either missing or duplicated, and or the next level of detail of testing, which is whole exome or whole genome sequencing, and that's looking for changes at the individual gene level. Okay, so the microarray is looking for big chunks with a lot of genes involved. The exome and genome are looking for single genes. And what we find with all this testing that's now done clinically in a lot of places is that we can find a cause in up to 15% of individuals with a neurodevelopmental disorder. Now, we wrote a paper recently that looked at like, well, what's the reality of this like in the real world? And I'm sure some of you have lived this firsthand. I see it all the time in our patients, especially here at Children's Hospital. There's still a really big lag time between when a parent first shows concerns about a developmental issue and when that concern is validated, but also when they actually get a genetic diagnosis. So we're trying to get better at that and improve access to testing, because what we're finding in these like 15% of people that have a known genetic cause is that this list is meant to be for effect. You don't have to read all these. Is that we're finding a lot of different genes. It's not like there's one gene that causes epilepsy and autism, right? It's a bunch of different genes and copy number variants. So these variants are like the big chunks of DNA that I talked about, chromosomal changes that we see with the microarray. And this is a list of like the single gene disorders. And what's interesting is there's a huge overlap between epilepsy genes and the neurodevelopmental genes. So if you look on the left at this list, which again, you don't have to memorize, just get a sense of there's a lot. Most of these genes cause both neurodevelopmental disorders and epilepsy. And so we think genetic testing is especially high yield in individuals that have both. So if you happen to be a family that has not yet been offered genetic testing, you can use this as evidence to kind of advocate for it. Again, recognizing that sometimes like the big limitation is just in our ability to get that testing covered by insurance. And a lot of us around the country are working really hard on advocating for that more so that it is covered, so that parents and families can get that information. And I have a slide and a couple slides to tell you why it even matters. You might say like, okay, well, whatever, we're going to get a diagnosis. Why does that change things? And I'll tell you in a second why that is. But what's interesting is what we know by looking, many of us study these individual genetic causes, right? And it turns out that there's a couple of really big themes that come out when we study neurodevelopmental disorders and epilepsy in these genetic syndromes, okay? And the main take home is that we do see that epilepsy, so in these genetic syndromes, kids who have epilepsy tend to have more significant challenges, more severe neurodevelopmental disorders, right? So more severe epilepsy goes hand in hand with more severe neurodevelopmental issues, which really, to me, is just more of an argument for why we should be aggressive about treating seizures, right? Because those two things kind of go hand in hand. I'll give you like two examples of this really quickly. So I know that there's some tuberous sclerosis. There's some families here with kids or adults with TSC. So TSC is a genetic condition. I won't get into all the details, but it's a genetic condition that is highly associated with both neurodevelopmental disorders and epilepsy. In fact, the TSC community has created this term called TAND, TSC-associated neuropsychiatric disorders. That's like really everything in the DSM, but it really speaks to the fact that kids with TSC and adults with TSC really do face a lot of different neurodevelopmental and neuropsychiatric conditions. And these kids are often diagnosed at birth because of some of the benign tumors that they get based on their TSC. So we've been able to actually look at neurodevelopmental conditions and epilepsy in babies and young children with TSC. And a couple of key findings here. One is that it turns out that if you look at toddlers and young children with TSC, those with seizures, and you can see that just here in red, have lower scores on their developmental testing, on their measures of adaptive skills, just like daily living skills, on their measures of language overall. Okay, right? So again, just showing that epilepsy kind of goes hand in hand with more significant challenges in that space. We've also studied babies with TSC and followed them in the first 3 years of life. And what we find is that in this purple is the infants who go on to be diagnosed with autism. You can see the kids who go on to have autism, and this is a scale that's looking at their cognitive skills. Kids with autism do tend to have more significant delays in their cognitive skills. But what's really important about this figure is what we found was that in these kids with neurodevelopmental disorders, that there was a significant relationship or interaction, if we're using like fancy statistics, between their seizure severity and their like change over time, which means that it looks like kids who go on to have autism are more sensitive to those early seizures. And so again, it just is more sort of, information for us to say, we got to be thinking about treating these seizures early because it's important for their development. We found similar things in other genetic conditions. This is another one called Dup15q syndrome. There may be some families here who have kids with Dup15q on the call. Again, it's another copy variant syndrome that's really strongly associated with autism and neurodevelopmental disorders and epilepsy. And we did a big study. And again, just quickly to give you basic summary is that what we find is that this is a measure of cognition. This is daily living skills, that kids who have epilepsy have lower scores. And so again, this is not to tell you that if your child has epilepsy, they're going to have low neurodevelopmental outcomes. It means that we as clinicians need to take the epilepsy really seriously because we know it goes hand in hand with development. And to me, it also really reinforces, I show these data to clinicians all the time to say, if you have a child in your clinic with a genetic syndrome and epilepsy, I hope you're screening and testing for neurodevelopmental diagnoses because they're at very high risk for having challenges and delays in these different domains. So like here you can see kids with epilepsy, which is in the red, have lower, language, adaptive skills, daily living skills, socialization scores, and motor skills. So across the board, we have to be paying attention to it. So before I finish this section, and then we're going to get into the meat of talking about diagnoses and how do we make these diagnoses, I really think this is an important slide because I get asked this question all the time, which is, I have a child, a parent will come to me, their child has epilepsy or their child has a neurodevelopmental disorder. And I recommend genetic testing because it's recommended, right, as a medical workup. And parents often will say, well, why do I need the testing? Okay, sure, it might give you some data about the cause, but is it just an academic exercise, or is there something more we gain? And I'll tell you, when I was in training, which is now like 15 years ago, a long time ago, 20 years ago, actually, the answer was largely academic. It gave us information about, oh, this is the cause. Maybe we can start learning about why this gene causes these, difficulties in the brain. But the field has totally changed in the last 20 years. And what's happened is patient advocacy groups form, and some of you may be involved with them, right? So parents get together. You guys are the most powerful engine to drive progress, actually. And, parents get together and say, oh, I have a child with a specific genetic variant. And you get enough parents together through social media and other platforms, and you can create a patient advocacy group. And so that allows parents to link up to each other. And then what happens with these patient advocacy groups is these groups are very proactive about developing natural history studies or registries that help understand what the needs are of these kids or adults. They partner with researchers who might be interested in the gene to test animal models so that they can test treatments, right? And so it starts giving a lot of guidance around what's the course of this specific genetic condition over time. What's the prognosis? Are there, it involves the families directly in research. And lastly, it's really in the last, I'd say 5 to 7 years, opened the door for what we call precision health, which is there are treatments being developed that target the cause. And we believe that those treatments that target the cause should help with both the epilepsy and the neurodevelopmental issues. And there's a lot of clinical trials being done right now. My group does a lot of research in kind of working with patient advocacy groups on what we call trial readiness, meaning how does the patient community get together to be ready for a clinical trial once a treatment is developed? And I won't get into all the details of what needs to happen, but just to say that if you're a part of a patient advocacy group, this is really the area of focus now. We want to have treatments to help your kids and, and other loved ones. Okay. So with that, I'm going to go on to really the meat of this for you guys over the next 10, 15 minutes, which is how do we diagnose and treat these, right? These NDDs. And so this is where we go to the basics. And I want to share this with you because I think it can be really helpful from the standpoint of, again, advocating for what kind of assessments your child or adult might need. So again, I'm going to remind you, these are the neurodevelopmental diagnoses we're talking about. The order is flipped, but I'm going to start with global delay, right? So what is global developmental delay? Global developmental delay, first of all, must be diagnosed before age 5. It is not a diagnosis that persists after age 5. After age 5, a child usually will fall into the diagnosis of intellectual disability, which we'll talk about in a minute. But global delay essentially means having delays in at least 2 developmental domains. And these are the types of these are the domains we're talking about: motor, language, cognition, social, daily living. And really, to be honest, when I'm seeing kids in clinic, usually kids who are diagnosed with global delay have delays in motor and language. Those are really the 2 big ones. There's different tests that can be performed, and I'm giving you this. I'll share these slides with Audrey at the end, but I put little bubbles about the tests that are performed so that if you're in a diagnostic assessment, you can sort of have some familiarity. The 2 big tests that we use to look at just general development are the Mullen or the Bailey. No like major advantage of one over the other. It just depends on what the clinic is experienced in doing. But these are going to assess your young child's developmental skills. And what it gives you is a developmental quotient, or a DQ, that basically tells you and the clinician what is the age equivalence of the child. And then based on like the actual age, you can create kind of a baby IQ, which is really a DQ, or a developmental quotient. So that's global delay. It's delay in at least 2 developmental domains. So what is intellectual disability? So intellectual disability is based on IQ. So you have to be able to do an IQ test to make an ID diagnosis. And as you'll see, ID is based on having an IQ of 70 or below. So if the IQ is tested above 70, it is not intellectual disability. Now, there's 2 ways that we, again, as clinicians, determine if ID is mild, moderate, severe, or profound. And it's based on the actual IQ along with what we call adaptive skills. So we want to know, how does the child or adult live in the world, right? Because if there are definitely instances where children will have, on paper, a lower IQ, but they're able to do a lot in the real world. They can, count money. They can read time on a clock. They have basic number concepts. They can make sure they take care of their daily living skills like bathing and brushing and, they're toilet trained and all those things. And so that kind of individual might actually be deemed a little bit less severe, even if their IQ is lower, right? So we kind of base the level of severity on both IQ and the amount of, support they need in their like daily living skills. And again, I'm telling you this not because you have to go out and like be proactively diagnosing anything, but I think it's helpful to have this when someone's giving you a diagnosis to say, well, did you do an actual IQ test if you're calling this ID? Or the flip side is to actually make sure you're advocating for an IQ test if someone's giving your child an ID diagnosis. So what are the kinds of tests you're going to hear about, right? And I'm not going to get into these, but just IQ tests, there's a bunch of different ones out there. Stanford Binet, the differential ability scale, lighter, and all the Wechsler series, like the WIPSI and the WISC. We in our group really like the differential ability scale for kids who are a little bit more impaired because they have either a medical issue, epilepsy, other genetic diagnoses where they're a little bit more challenged. The DOS is able to kind of pick up on abilities that a child has. And so their scores tend to give us a little bit more of a range. We also have tests for this adaptive behavior, like how does a child live in the world? And the main one is called the Vineland. Some of you may have done that. It's a parent interview that asks parents about different aspects of the child's behavior or adult's behavior day to day. So that's intellectual disability. Again, cannot be diagnosed until a child is at least 5 years old. And I will make the other really important point is we do not use IQ tests unless a child is developmentally at least 5 years old. So I have kids that we see in clinic who, again, have different genetic syndromes, might have epilepsy, and they're quite developmentally delayed. So they might chronologically be a 7-year-old, but developmentally, they're still at about a 2 or 3 or 4-year-old level. That child should not be getting IQ tests because we may not get a score that's really reflective of their ability because the test just might not be appropriate for them yet. And so in those cases, we actually will go back and use, the Mullen or the Bailey, even though it's out of range, just to get a basic proxy of where a child is developmentally. So I think that's important to remember. But again, just so you know that to make a really rigorous ID diagnosis, you do need to have some of this testing done. Okay, so third is autism, which is the one we always get asked about. How do you make an autism diagnosis? So I want to take a step back and remind all of you what the autism diagnosis even entails. You have to have symptoms and signs in 2 domains. So the first is impairment or challenges in social communication. So what does that mean? Here are the 3 areas. Deficits or challenges, and this is taken straight out of the DSM. So this is not my language. I don't love using terms like deficits, but it's in here. So I'm putting it in here. Deficits in social emotional reciprocity. So what does that mean? Like back and forth, right? Are they able to kind of banter back and forth in a social way? Second is deficits or challenges in nonverbal communication. So what are examples of that? Things like eye contact, pointing, gesturing, social smiling, those kinds of things. And then the last is deficits in developing, maintaining, and understanding relationships. So you can imagine, like, this looks really different in a child who's 4 versus a child who's 10 versus a child or adult who's 20. And there are examples of these in the DSM for all of these, but the child or adult has to meet all 3 of those criteria in that one domain. The second domain is repetitive behaviors and restricted interests. And there's 4 items in this. The child or adult has to meet at least 3. So you don't need all 4 in this category. And those are stereotyped or repetitive movements or repetitive use of objects or speech. Inflexibility, so just real struggle with, with changing routines and things like that. Highly fixated interests, so being really stuck on certain topics or play items or other things, and becoming very challenging to move away from those. And then lastly, and this was actually new in the new DSM, is sensory issues. So either being overly reactive or under-reactive to sensory input. So we see that kids sometimes are really overly sensitive to sounds or overly sensitive to textures or tastes or things like that, or they seem hypo-responsive. Parents will tell me it seems like, he or she has no sense of pain. They'll put their hand on a hot stove and not even react. And that's part of this diagnosis. So you have to have 3 of the 4 of those to meet criteria. The really key point here is that, literally we all have some little traits that might meet some of these criteria. Everyone's a little bit rigid sometimes, or a little bit sensitive, or may not be, super social. But the key with the autism diagnosis is it has to cause functional impairment. It's got to get in the way of a child's ability to sort of be successful either in school or with friends or at home or in a job, in any setting, right? It can't just be a trait. It has to be something that really gets in the way of their functioning. So how do we diagnose autism? Well, again, it's a list of behaviors, just like the other diagnoses, but just like the other diagnoses, there are tests. And the 3 main ones that we use, the first is just going through this list in the DSM. And when I see kids in clinic, I'm able to often make that autism diagnosis just based on going through the checklist in the DSM. And a good trained clinician should be able to do that. Sometimes it's a little more complicated though, and we're not really sure if it's really autism or something else. And then some more targeted tests can be done. The 2 gold standard tests that are used is the ADI, which is an interview with a parent or caregiver. And it really goes through both current behaviors as well as how the child behaved earlier in life if they're younger, or if they're older, I should say. So this is a parent interview. It's pretty long. It's a couple hours. But it gets, again, a lot of good data and information from a parent or caregiver. And then the second is the ADOS, which is a play-based direct assessment of the child. And it's trying to pull out those behaviors that I listed before. So those are the kinds of, assessments you should be getting if someone is doing a comprehensive eval to diagnose your child with autism. Now, again, I'll reiterate, there are times I see kids in clinic, I can make a diagnosis without doing an ADOS and an ADI because the signs and symptoms are very clear. And an experienced clinician should be able to do that. But sometimes we do need this testing. What I want to really remind you as caregivers about is that if you are undergoing a comprehensive diagnostic assessment for your child, because it's recommended by the school or because you've requested it or whatever that might be, I want to give you some key tips here for you to be good advocates for this. So one is that the testing should include, all developmental and behavioral domains of interest. So in a child with epilepsy, for instance, if there's a question about autism, I really think that they should be also assessing for other domains as listed here, right? Because autism rarely occurs in a perfect silo. And so you should make sure that they're testing for cognitive skills, or if your child's younger, developmental skills, looking at language and motor, again, other behavioral challenges or mood issues. Like, there should be a holistic approach to this kind of assessment. The assessment should also be developmentally appropriate. Like I mentioned before, right? The tests we do are based on, they're all standardized on kids who are typically developing, right? They're not standardized for kids who have challenges or developmental delays. And so it's really important that the people doing the testing are doing testing that's appropriate for your child's developmental level. Because otherwise what happens is we're doing tests that are not appropriate for the child's ability. And then you don't get scores that are reflective of what your child can actually do. And I see it all the time where we get these scores that look really low and the child has a lot of skills that just weren't captured because of the type of testing that was done. I also think testing should take place with the recognition that kids need breaks and it's tiring. So if you go out and get a developmental test, and I get patients who come to me and they're like, oh yeah, we did a whole comprehensive test and they have a whole packet of information from the testing. And they're like, oh yeah, we did it all in like 3 hours, just powered through it. And I take that, I have skepticism about how accurate that testing actually is going to be. We usually take a couple of days to do testing with kids because you need breaks. And the child, you guys know this, right? Like, if your child's not in a great mood, or they're hungry, or they're tired, or they've had a long car ride, they're not going to perform to their maximum ability. And we want to see maximum ability when we're doing testing. And then I would just really caution you to take standardized scores, meaning standardized scores are like the scores that are like normed on a general population, right? So like a normal quote IQ is 100, right? That's like the standard score. And there's standard scores normed at 100 for every test you'll do. Take them with a grain of salt, because I always emphasize with parents that this kind of testing is done to help make a diagnosis and perhaps to track progress over time. It is not meant to compare your child to 10 other kids. It is not meant to compare your child to a population of kids who've had this test done. So I always try to really focus on, like, what are the skills that were elicited in this test? What are the positives that we saw that your child was able to do? Let's focus on those things, right? And what are the areas where there were some challenges? Let's actually think about how to design interventions to focus on those. Okay, I have two quick slides on diagnosis, and then we're going to go to treatment. And the two quick slides are that there's two really big kind of co-occurring conditions that occur in kids with both epilepsy and neurodevelopmental disorders that we as clinicians have to take seriously. And we find often the parents, because you guys are so great at just handling everything, don't even complain about. But the reason it's important to complain about these things is that there's actually treatments for them, and the treatments can actually really improve quality of life and actually also cognition and development. So the first is insomnia, which is just not getting enough sleep. So what we find in kids with neurodevelopmental disorders and epilepsy is kids often don't sleep well, and neither do parents then. And I know many of you are probably thinking to yourselves, God, I totally relate to this. I have so many parents that have for years not slept well because of their child's insomnia. It might be that they don't go to bed on time or well, it's hard to get them to sleep, or they wake up a bunch of times in the middle of the night. And when we get to treatment in a minute, we'll talk about treatments for this, but insomnia is definitely a big issue. The other really big one is behavioral challenges. So aggression, irritability, mood swings. And that's also something we as clinicians should be screening for, but you should also tell your clinicians when this is happening. Okay, so now we're going to talk about treatment quickly. And the mainstay of treatment for a child with a neurodevelopmental disorder, and it's kind of unsatisfying, but it's true, is behavioral intervention. And the recommendation, and this is based on the National Research Council from a long time ago, is that kids through school actually should get high treatment intensity with a really low staff to student ratio, with ideally teachers with special expertise in autism, and individualized programs for each child. And this is where the law comes into play. And it's important to kind of know about this, right? Which is that there was an act enacted in 1975, which is the year I was born, so it's 50 years old now, called the IDEA, Individuals with Disabilities Education Act. It's a federal law that really requires that if a child meets criteria for one of the indications, which I'll show you in a second, the child should get an IEP, an individualized education plan in school. And that means specialized instruction that's individualized to meet the child's unique needs. This is the list of the different diagnoses that fall into an IEP designation. And you can see most kids with epilepsy fall into one of these, actually. And if you have a formal neurodevelopmental diagnosis, that helps even more. And so the IEP is a bunch of components, and I'm not going to get into this in detail. I bring this up, though, because this is really important, I think, as a parent to know about, so that you can be proactive in asking questions about how they're making decisions on each of these areas. And I think for us as clinicians, it's important for us to actually know, when we get given an IEP from a parent, what should we actually be paying attention to? So what the IEP involves is, first it'll give, where is the student now? So present level of performance. Where are they going? What are the goals and objectives for the next year? What are we going to give them to get them there? And then how we measure that we've gotten there. That's the bottom line. So I have parents who show me the IEP, and I'll be honest, the present level of performance is not accurate. They've totally underdetermined the child's ability. So the problem with that is the rest of it that goes in line with that is not going to be a successful IEP, because they've really not given the child the best chance for making even further progress. So I think it's really important to have to be aware of the fact that you can question any of these if you don't agree with them, and you do not have to sign your IEP if you don't agree. I mean, it then takes some work to advocate for a modification, but I always remind parents, you don't have to sign the IEP if you don't agree with what they've written for these things. Okay, so then what about other behavioral interventions? We talked about school, right? And my big take home here is that specifically for autism, what's been shown is that behavioral intervention can be very helpful. And so the question is like, what is behavioral intervention? And it actually falls under this huge umbrella term called ABA. And I think sometimes ABA gets a bad rap because people associate it with just with one type of intervention that I'll mention in a second, called discrete trial training, which is really repetitive and can feel sometimes even punitive, even though it's not meant to be. But there's a lot of different types of ABA. All ABA means is it's an intervention that tries to shape and reinforce new behaviors while reducing undesirable ones. So I really like ABA strategies for kids when parents are trying to work on things like toileting or aggressive behaviors, even sleep sometimes. Not quite as good, I think, for things like social skills, although that it can be used for that as well. And I won't get into all these details. Again, you guys will have these slides, but I want to emphasize that there's a bunch of different kinds. And the way that they really differ is based on the way it's delivered. So discrete trial training is very adult led. The interventionist is providing repeated reinforcements around helping a child learn whatever it is, a skill, a cognitive ability, whatever it might be. Whereas then there's ones that are much more child-led and play-based, like Jasper, pivotal response treatment. Some people don't think of floor time as ABA. It's sort of separate, but it's the most play-based intervention for a child with autism. So these are all available. And I always get asked the question, well, which one is evidence-based or which one should we recommend? Unfortunately, it often depends on what's available. But I would say, you can be an informed consumer and say, I think my kid would do much better with something a little more play-based. Is there an agency that has something that's more play-based, child-led than the discrete trial that we often see with like traditional ABA? And you can ask those questions of your interventionists. We also have great treatments for the comorbidity. So we talked about for autism and really all the neurodevelopmental disorders, treatment is behavioral. But we do have really good pharmacological treatments for a couple of things. One is for insomnia. So the treatment of sleep issues is a combo of behavioral and medications. I just will alert you to the fact that Autism Speaks on their website has these toolkits for parents, and they have a really good toolkit on sleep that kind of goes through strategies that you can do to work with your child to help them either get to sleep or stay asleep. And you can get that online. I'm happy to share with Audrey the link to that if you guys want that. And then, other kinds of tips on sleep hygiene. The big one is preventing screens at night. We all are guilty of it, but our kids with epilepsy, neurodevelopmental disorders are often much more vulnerable to those to the effects of light when they're going to sleep. So I really try to have parents avoid it, at least for the like half an hour before bedtime. But there are also medications, and melatonin has been really well studied to prevent or to help with the onset of sleep, meaning helping kids fall asleep. And then there's some meds like the alpha agonists like clonidine, and then meds like trazodone that can really help, and gabapentin that can help keep kids asleep at night. Not a lot of big clinical trials, unfortunately. So we're doing a lot of this with small studies and just our own anecdotal evidence, but melatonin's probably been the one that's been well studied. My big cautionary tale to you guys is melatonin varies. Like you can see this, like I just have an example of all the bottles over the counter, right? And so none of them are really FDA regulated. So if you buy one and you like it, just stick to that one, because a different bottle that you buy from a different company might be a little bit different. That's like really the main recommendation I give. The other big recommendation with melatonin is I often find that parents underdose it. So they'll come in and they'll say, oh, it's not working, and they're giving 0.5 milligram. The clinical trials have studied doses around 5 to 10 milligrams. So you want to be able to dose it properly. And again, talk to your provider about that. And then the other big medication is for behavioral challenges. It turns out there's one set of meds that are FDA approved for autism, and it's for irritability or behavioral challenges in kids with autism. And those two medications are risperidone and aripiprazole or Abilify. They're great medications. I will say they do have side effects like every medication, weight gain and sedation being the really big ones. And so we always have to take that with, a grain of salt and make sure that the side effect or the benefit is outweighing the possible side effects. So with any medication that a provider is using, you just make sure that they're going to start low and go really slowly, because our kids can be very sensitive. And if we have children who also are on a bunch of antiepileptics, there's always the risk for having, side effects that are sort of adding on to each other. Okay, so, and then the last thing I'll say is that a lot of families use, you guys probably do too, complementary alternative treatments. We've learned that over half of our families are using something. And so I think it's important to just tell your provider if you're using something, because there can be some interaction. Okay, so in the interest of time, what I'm going to do, because I want to have time for questions, is I'm going to actually skip ahead. I was going to show you some data, but I'm not going to do that. Instead, I wanted to show you these last two slides. And then I'm going to open it up. We have about 15 minutes for questions. And if there's no questions, then I can show you some data if you want. And actually the question really, there's sort of let's see, where's my slide? So this is really the like $1 million question for all of us, right? Is like, if you treat epilepsy really well, can you actually improve neurodevelopmental outcomes? And what I will say, without showing you data right now, is there's really nice research being done in this space in genetic conditions, especially ones where we diagnose the genetic condition really early in life. And tuberous sclerosis is one of those. Again, I won't show you the data now, but we've done studies that have looked at whether early epilepsy prevention can help later neurodevelopmental outcomes. And the gestalt is basically yes. We really believe that like the better we can do to control epilepsy early, the better our developmental outcomes will be. But I want to show you this quickly. So I kind of did some, deep diving into the literature. And I really liked this review, which is on LGS. And this, group looked at basically all the literature they could find on like studies that have looked at cognitive and behavioral outcomes with treatment for seizures. And there's some key principles that I pulled out of this for you guys, right? So one is seizure control is important to optimize developmental outcomes, whether that's surgery, whether that's medications, whether it's other non-pharmacological treatments like VNS, which is kind of surgery, but not, brain surgery per se, or neuromodulation or other things. What they really highlighted was that medications, which I'm sure you all agree with, can have varied effects on cognition and behavior, because you have this kind of balance of the med is helping with the epilepsy, which is helpful for development, but the meds also can have side effects that actually can affect behavior and development. And some examples are, Topamax or topiramate or zonisamide can cause cognitive dulling. Some meds can cause irritability. Keppra or levetiracetam is like the #1 culprit there. Not everyone, but definitely we see it. Clobazam, zonisamide as well. And so we as clinicians are always balancing those things, because we want to be aggressive with the seizures. We don't want the meds to create so many side effects that we're undermining development and behavior. And so what I would say as a take home for all of you with this bullet point is, if you're going in to get a neurodevelopmental assessment and you have just started a new medication, or if your child's on a medication that is causing some of these side effects, please make sure you let the clinician know this, or the team that's assessing know, so they can kind of be aware that that might be a factor. The group also in their big review did find that non-pharmacological treatments like surgical interventions can provide more cognitive and behavioral benefits. And there was one paper that actually specifically looked at cognitive outcomes after pediatric surgery and actually found a big range of outcomes, as you may imagine, but most kids showed some improvement in at least some cognitive domains. And there were a bunch of predictors of like who did better based on how affected a child was before the surgery even happened. And so with that, I'm just going to summarize and stop, and then I'll open it up for questions, which is, neurodevelopmental disorders are really prevalent in epilepsy, as I mentioned, and so we have to be proactive about screening and diagnosis. So please advocate for that if your clinician is not doing it. We diagnose these diagnoses based on behaviors. So you are going to get some variability in the way these diagnoses are made, but accurate diagnoses are really important for services, right? Like getting a good IEP or getting behavioral interventions like ABA. And again, a lot of research is being done now on how we can best optimize developmental outcomes in kids by intervening at the right times in kids with epilepsy. And so with that, I'll stop. I showed a little bit of data, so that's my group, but I'll really say thank you and answer questions.
Wow, that was amazing.
I didn't show data because
Incredible.
I wanted to have time for questions, so sorry about that, but I'm happy to, I'll give you the PDF of
Totally fine. Yes,
the
now I
call.
get it. And thank you. I think that's really helpful. Uh, I think I went through the questions that came in advance while you were
Yeah.
speaking, and I do feel like you've addressed pretty much everything that came in advance. There's a question in the chat I'm going to ask in a modified way in a minute. But the first thing that came up for me is that sometimes parents are afraid of a diagnosis or a label,
Mhm.
and they don't want to go get the testing because they don't want their child to be labeled with ID, like intellectual
Yeah.
disability, but they'd be happy to have that autism label. How do you counsel families when there's fear of even seeking that diagnosis? I mean, it's one thing to know where to go, which now we know we need to ask for that referral and make sure we get an appropriate evaluation. But what about that sense of losing some control over your child's, how
Yeah.
they'll be viewed, I
Great
guess, by the
question. And so
world?
here's how I sort of conceptualize and formulate this, okay, which is that each of these diagnoses, and I showed you the list for autism, there's a similar list in DSM for ID and global delay and speak, it is literally, each of these diagnoses is describing a constellation of symptoms and signs. That is all it,
Mm-hmm.
how you
Yeah.
use it, how you choose to again, formulate that as like an identity or non-identity is really actually up to you. It is a diagnosis that, again, it provides a label that actually explains at least a constellation of symptoms. And without that, we can call it a label. Without that diagnosis, it becomes very hard for a school, a service provider, a physician, another clinician to figure out what the right kind of treatment plan should be. Right.
Yeah.
I mean, if
Yeah.
you walked in and said, oh, my child has repetitive behaviors, rigidity, some sensory issues, some, challenges with relationships, and like that's a lot, right? If you say my child has
Mhm.
autism, like it kind of captures those things.
Yeah.
And a good clinician and a good school system should recognize, well, yeah, but autism, it looks like different things to different people. So let's actually figure out within your child's autism diagnosis, what are the areas of need? What are the areas
Mhm.
of strength, right? What should that IEP and that profile, the educational offerings look like? And it's
Yeah.
going to vary by child. So I
Yeah.
really try to move away from the label and more think about it as like, it's a way to provide a concrete explanation for a concrete term for a constellation of symptoms or behaviors.
Yeah. We do see that the autism diagnosis or label does help with opening the door to services both in the school
Yes,
setting and in the adult world.
yes,
And sometimes services won't be provided unless the child has that label. So it's unfortunate, but that is sort of the reality that we're seeing.
it
Okay, I have
is
a couple.
unfortunate. Yeah, but that
Yeah.
is that
Yeah.
is the case. So
Yeah. All right, so this is very specific, and I know you're not going to speak specifically to epilepsy surgery per se, but the question is about if the child had, in this case, the removal of a hemisphere, or I would say any epilepsy surgery that is, removing or stimulating part of the brain.
yeah.
Do you find that they respond to psychiatric medications differently than a child with a
Mm.
typical brain structure and the same diagnosis? Medications that should work for a neurodevelopmental symptom are not helping. And then when or how do we know when medications and behavioral therapies are not the appropriate treatment? It's kind of a big
Great
question.
question. No, it's a great question. And on that slide where I talked about behavioral issues, I sort of listed, I made a point there about what I wrote is, any behavior has a cause, a root, and we have to figure out what that cause is. And I find sometimes that what happens in the medical community, and I say this to someone who's in the medical community, is we tend to like jump to medications as a band-aid for a symptom. And I always try to take a
Hmm.
step back and say, well, why is that behavior occurring? Because if we can start figuring that out and treat that, it should work. Whether your child has had a hemispherectomy, whether your child has a genetic syndrome, whether your child has an IQ of 30 or an IQ of 130. But I think that when children are a little bit more complex neurodevelopmentally, maybe a little more impaired cognitively or from a language standpoint, it's harder to unpack why a behavior is occurring. But I think it's
Hmm.
super important for us to be doing that because, for instance, let's just take aggression, right? So I get a patient who comes to me, a family comes to me, my child's really aggressive. Why? Well, I've had cases where it turned out they were aggressive because they had a dental abscess that no one had actually looked at into their teeth
Yeah.
because
Yeah.
they found the dental assessment so difficult, right? Whereas others, it's like pure irritability and risperidone might be helpful. Others, it's anxiety, and then you have to treat the anxiety, or it might be insomnia. They're sleeping horribly, so they're irritable and aggressive, so we treat the sleep. So that's really important. To directly answer the question about do kids who have had surgery respond differently to meds? Absolutely. I actually will just say any child who's not just like a typically developing kid who has a little anxiety, right? Or has a little ADHD, any child with any other neurological diagnosis is going to respond differently to meds. I wish I could tell you there was a pattern, like, oh, they're definitely going to do well with med X versus med Y. That is impossible to predict. So what I will say
Yeah.
is this, it's what I said a little earlier, is anytime you're started on a medication, two principles must apply. One, start at the lowest possible dose and increase as slowly as possible. And don't give up if it feels like there might be a little bit of a side effect or it's not working. If it's, of course, a side effect that is absolutely impossible to tolerate, that's different. But give it time. I always ask parents to give me a month with any med I'm starting because it takes time. So that's principle number
Mm-hmm.
one. Principle number two is we should never be making two changes at once. So do not let someone start you on a med and take off another med at the same time, because then you have
Mm-hmm.
no idea what worked and didn't work. So
Yeah.
we want the med changes to be done slowly and rationally and methodically. And then we're
Mm-hmm.
going to know which work. But sometimes there's a little bit more trial and error with our
Yeah.
kids who have had surgery or who have epilepsy for sure.
Yeah, I think that's why I'm so interested in your work is I feel like the surgery is not what causes the neurodevelopmental disorder. It's all the history of
Absolutely.
intractable epilepsy, the underlying condition, the
Yes.
damage, early damage to the brain. That's what we really need to understand.
Yep.
And it's not about surgery can actually improve outcomes, like you said, in
Yep.
some cases. Okay, two practical questions to end because we only have a few minutes left. If I wanted to pursue testing for intellectual disability, would I ask my child's primary provider or would it be their neurologist? And then in that vein, how long is the wait time for
Oh,
neuropsych testing or evaluation through your program? And I know this is a big problem for a lot of families. So maybe you
I'm
could start by who would the parent ask, and then we could talk a little bit about wait times.
great. And I was going to ask, where do you live? Because that's how I answer that question. So it is the biggest. I mean, there's a lot of crises ongoing right now in pediatric healthcare, but I would say this one is like one of the biggest is that we don't have enough people to be doing timely
Hmm.
testing, which is
Yeah.
why I always say like a good developmental behavioral pediatrician or even child neurologist should be able to make these diagnoses using DSM in the clinic. Now ID is a little tougher if you're kind of on the fence because you need an IQ test, right? And so but otherwise we should be able to do it in the clinic. If you need a referral for testing, you can get that. Usually we recommend doing it through your pediatrician. And then the
Hmm.
question is like, who does the testing, right? So that depends on your healthcare institution. But most institutions will have some team that's doing testing, whether it sits in child psychiatry, whether it sits in developmental behavioral peds, or whether it sits in child neurology. That really depends on the institution. I can give examples of all three all around the country.
Yeah.
I, as a child neurologist, have been really trying nationally to just empower child neurologists to be able to make diagnoses, because I think it just sets the stage, as I showed you, for like just starting to get the appropriate school services and the appropriate assessments. The other thing I'll say about assessments is that if you don't go through the clinical route, most states have, like in California, it's called the Regional Center, but most states have a state-funded program that should also be able to offer testing. It totally depends
Hmm.
on the state, how willing they are to do it. But under 3, early intervention is, that's IDEA, like until 3 is your local early intervention
Yeah.
program. After 3, you
Yeah.
go into school. I didn't mention that in my slide, sorry. So if your child is really young, it can be done through your local regional center or equivalent.
Hmm.
And then after 3, either the regional center will do it or school will do testing. So like when you're getting an IEP
Hmm.
evaluation, the school has to do testing. What I find is that there's variability in the kind of quality of testing that gets done. And sometimes schools are reluctant to make diagnoses. They're going to look at function, but they want someone else to make the actual diagnosis.
Yeah.
And then
Yeah.
they'll punt it back, right? To answer your waitlist question quickly, our team evaluations here, we've worked really hard on getting them to be quicker. We're still at about 3 to 6 months. Um, in
Not
our
bad,
neurology
actually.
program. It's better than, yes, and that is because
Yeah.
we have kind of a tiered system where if it's deemed based on triage, that the child can get a pretty quick assessment and doesn't need the whole team and the whole list of tests that I showed you
Mhm.
earlier, then they might get referred back to like neurology and to see one of my NDD specialists, and they can see, a child in an hour or two and make a diagnosis.
Okay,
So it
great.
really
Yeah.
depends.
I know I'm in the San Francisco Bay Area, and there sometimes could be a year or more
Yes,
wait,
I
and
know.
I
And then you're like, you're not lost a window, but you're like,
yeah.
you've lost possibly an opportunity to get some services.
Yeah, I just tell families, get on the wait list, and if there's a cancellation, drop
Yep,
everything and get your kid there that day because it's so worth it, and, I feel like the report is sometimes really overwhelming to read, so
yep.
you might need to read it and set it down for a week and come back to it and reread it, and all the information you just shared as parents, taking it in, that's a lot. And then when it's about your child, there's a very personal component, but that information is so important and hopefully can be helpful to help, like you said, with school services and adult services and lots of other resources for the family.
And force whoever's doing your report, once they do your workup, like you need to force them to sit with you, whether it's over
Okay.
telehealth or in person, and go through that report. The last thing you should be doing is reading a bunch of scores, because that
Yeah.
is a horrible thing to have to do, period. And so you should ask someone to walk through and explain. When we do reports, even for research, like we do a lot of testing for research, but we give parents reports they can use
Mm.
for services. We really highlight, like, here's all the awesome stuff your kid did. And here's some great areas of strength. And here's some areas that they need some help with. Because the strengths
Mm.
are as important, right? Because you can leverage those strengths when you're, again, thinking about the kinds of activities he or she might like, or the kinds of services they might need
Mhm.
or enjoy. The strengths are as important, I think.
Yeah. Well, this was really phenomenal. I'm so grateful for you taking time out of your extremely busy schedule to join us today. And a big round of applause. And hope to see you at Epilepsy Awareness Day this year or at
Yes.
some future event. And thank you all for attending.